Hey, everybody. I want to welcome everybody. We're in Coleman, Alabama for everybody that's online, and we're here to do our third annual MS Symposium here at Coleman. All right, my name is Stuart Schlossman. I'm president and founder of MS Views and News. I too have MS. You all know the story already. Today's program, I would like to thank Sandoz and Novartis for sponsoring us to do this event today, and I hope that you all can give them a round of applause and say thank you as well. All right, so Dr. LaGanke, you all know I'm not going to give him any introduction. For those who are online, if you don't know him, you're about to hear how much talk he's going to give you, okay?
Well, thank you all for coming and spending your time today, and hopefully you'll walk away with more knowledge about this condition. Little setback, I had a really good talk. I spent a lot of time on this. I was tweaking it, and I was saving it to the thumb drive to give to Bill over here, and it erased the whole thing. So I've been frantically trying to create some new ones, and so we're going to go with those, and I'm going to speak a lot, some not to slides from my recall over the last several days of preparing these slides, so bear with me a little bit. All right, so I don't know if that's me or not, but that's my writing anyway. So planting seeds, doing the best with what we have. And I had a lot of pictures of my garden and lots of really neat flowers in that presentation, so that slays me a little bit. But that's kind of was the theme, is that we all grow, we all kind of get better with age, hopefully sanctification, and have a positive impact on others as we get older. So that was kind of the theme of this talk, or is the theme of this talk. So first going to talk a little bit about care for the underserved populations, then discuss kind of MS and NMOSD. How many people know what NMOSD is? Not many. Good. You'll walk away with some knowledge then. And then living with a chronic disease, different aspects of that. So I'm the guy here. So NMOSD, neuromyelitis optica spectrum disorder, is a devastating condition. It was thought to be a severe form of MS for a while, and then we kind of figured it out a little bit and separated it from MS. It's an autoimmune attack against the aquaporin 4 receptor, which is responsible for water in the brain. It's a water channel. And antibodies against that do devastation to the optic nerves, the brain stem, and the spinal cord. So when I first was practicing here 25 years ago, someone had NMO, we would do our best with steroids or plasmapheresis to get them over their attack, but ultimately blindness and quadriplegia was their fate. Terrible, terrible autoimmune condition. And thank the good Lord, we now have some treatments. There are two peaks, childhood and then in the 40s. But there are immunotherapies now that have done a tremendous job at getting rid of those pathological antibodies. I think I have a slide with we covered that. So here's a slide, I'll go through it a bit. So GFP is kind of glial fibrillary protein, and that's kind of normal staining. And then aquaporin 4 IgG antibodies is in the middle. So the red are pathological antibodies that bind the green. And when you merge them together, you see the image over on the right. So that's the merged image of what it looks like. It should look like the top or the bottom, but when a person has antibodies, it attacks the protein and makes it look like that. So this is a particular one of the treatments we have for NMO. And before treatment, the antibodies are very high. You have a lot of red, and they're binding the GFAP or GFIP. And then 6 months after treatment, much less antibodies. And 1 year after, you can see almost no antibodies present. And the most recent medication or antibody treatment we've had for this condition, 0 relapses on the treatment. Phenomenally good at treating this condition now. which it was so devastating to see, so heart-wrenching before. So we're very blessed to have medications now that intervene significantly. Next. So CIS, clinically isolated syndrome, is a single demyelinating event. So if one had optic neuritis, let's say, and then had no lesions, nothing else, they'd be classified as CIS. We've had several revisions of our MS criteria over the years. Back in the 70s, it was Schumacher criteria, and then the Poser criteria, all trying to help us to diagnose MS because there's no test to diagnose MS. And we're trying to get better then at diagnosing earlier, not overdiagnosing, but diagnosing as early as we can because the impact is much greater when we treat earlier. And so the McDonald criteria came into being in 2001 and allowed us to treat people with one attack, but they had some other MRI abnormalities, or spinal fluid abnormality. We then could treat that person as having MS and had significant impact on decreasing their neurological worsening over time. So converting from CIS to MS, if you have 2 lesions and develop a new appropriate lesion or you have positive spinal fluid, then that would constitute a change from CIS to MS. One needs to follow people with true CIS because they can convert. And sometimes people will initially have their evaluation, have spinal tap, blood work, everything up. You don't have MS. This is just optic neuritis, and come back if you have problems. Well, that's a problem. That person needs to be followed because as in MS, 90% of brain lesions don't cause any symptoms. So how would you know? And yet brain damage is occurring, and you may have then a devastating attack that occurs that could have been prevented if we would have been able to diagnose that earlier and protect the person. So it's important to follow people with CIS for a while to ensure that they're not showing any signs of conversion to MS. Most disabling chronic neurological condition in the world for young adults, really 20 to 50. Potential 7 years lost life untreated. There's a study that showed that. That doesn't mean that applies to everybody. It's the most costly chronic neurological illness in the US. And the second most costly chronic condition of all conditions in the United States behind congestive heart failure. So it's very impactful in many people's lives, and even those who do not have illness, a lot of our resources are spent directed towards this. So it's a very important condition all the way around. Challenges. So a person with MS, things that you might not think about that one has to deal with. Job change, loss of employment, changed ability to raise a family, strained marriage or relationships, fear of the unknown, personal physical change, change in intimacy, possible gender role change, social isolation, helplessness, dependence, frustration, loss of control, anger, possible loss of driving, guilt of being a burden, just to mention a few. Those are things that we don't see, that may go on in a person's head, especially when they're first diagnosed and don't know much about this condition. All of these things one has to deal with. So you caregivers, myself included, because my mom had it, we don't see that. We don't necessarily know that's what's going on, and we need to be kind of attentive to somebody and what they're dealing, and maybe ask the questions. How are you dealing with this? How are you coping with that? Because they hide symptoms from us sometimes. They have plenty of other things to deal with. Next. So our clinic did a study that we presented at the American Academy of Neurology in Denver this April, looking at the first 300 patients that we treated with a medication or an antibody called alemtuzumab. And these people were followed for 8 to 9 years after treatment. Fortunately, 96% stable or better, 4% worse. Only 26 relapses or retreatments in that 8 to 9 years. The purpose of the study was to show we saved $152 million to society in the treatment, because this is a treatment that you take once, then 1 year later take, and then may not ever need another treatment. The average cost of a disease-modifying treatment in the US these days, a wholesale acquisition cost, is $100,000 a year. So every year you're not taking a treatment, you're saving $100,000 to society. So in our first 300, and we've now treated 900, but the analysis of the first 300 was huge. And the largest reason, the biggest reason that MS costs so much is the disease-modifying treatment, 70% of the cost of MS. So we have to find ways to improve upon that. So then, dealing with chronic, how do you deal with this chronic illness and chronic MS? Well, first, control the disease. So prevent progression. That's the first thing to do. Then manage symptoms well. Manage your other health issues. So just because you have MS doesn't mean you can't have heart disease and diabetes and all these other things. So we have to manage your health well. And then understanding the big picture, which I'll talk about. So we'll start with the treatments that we have. So the disease-modifying treatments that we have, shots and pills and sublingual form, some intravenous treatments, biosimilars, you heard about that to start the program today, generics, boo, and maybe BTK inhibitors, which are on the phase 3 trial landscape right now. I'm not going to go into each of those. I will just comment, you already heard about biosimilars, and this is what you heard a fair amount about as I heard out in the hall, so I'm not going to go into this too much. But when a biological agent loses its patent, then there's eligibility for another treatment to come in that's biosimilar. It has to be really close in pharmacokinetics and pharmacodynamics, PK/PD, and the standard is it just has to show that really close similarity in the lab, in vitro, not in people. And the FDA thinks they have a very rigorous system to ensure that the created other biologics is going to be very, very similar to the one we're talking about. And the reason we're talking about this is because there is a biosimilar to Tysabri that is approved in other parts of the world and is pending approval here in the United States, so maybe something that comes out. The reason biosimilars come is that they try to reduce costs. There's more than just drug costs, though. There's monitoring costs and lab tests, et cetera, that need to be done. So it's difficult in MS with an IV to have a biosimilar that's going to have a cost benefit, but we will see how that shakes out. Now, to the fairness of the one treatment in MS, the biosimilar, actually was tested in people too, not just in the lab and showing PK and PD similarities, but there were 200 patients or so in a TRIM study, and it showed clinical similarity. Of course, there has to be a clear benefit. We have a product that we're familiar with for 20 years, or I was with Tysabri in 1997 at UAB studying it for treatment of relapses. So a long time, and something else comes along, we just don't hop on the thing that comes along necessarily. It has to confer a clear benefit. But this is a competitive capitalistic society. So if somebody comes in and has something that confers a benefit, then we look at that. But that's the landscape right now. Now, I mentioned BTK, or Bruton tyrosine kinase inhibitors, as our next possible approved medication in MS. Well, here's a B cell. When the B cell is stimulated, it gets turned on, and it turns on this kinase, this enzyme. And this enzyme downstream may mature the B cell, cause proliferation. It may cause autoantibody production, boo, and may cause some cytokines that are pro-inflammatory and cause damage, boo. So BTK stimulation may cause problems in MS. Now, BTK is not just in B cells, but it's also in microglia. And if you go back in the literature, you don't see a whole lot about microglia in the MS world in the past. It was always T cell disease, and then B cells became an issue. But microglia are a very important part of this condition as well. And BTK is in that cell too. And so when that's stimulated, when the microglia is stimulated, then it can also turn to pro-inflammation and cause lots of problems. We haven't had anything approved that works on microglia. We've only been working on B cells and T cells. So this is the first possible type treatment that we have to also address another part that's important in MS. So microglia are native immune cells, and they monitor for injuries in the head and pathogens that go up in your brain. They help network in the brain. They help potentially remyelinate as well. So they have a lot of positive effects. Next. So they clean up damage with phagocytosis. They keep myelinated fibers myelinated and can remyelinate, and they kind of get rid of old synapses that you haven't used in a long time and don't need anymore. So they have very positive effects in our normal neurological health. Next. So that's on the one hand. But on the other hand, they can promote neurodegeneration and chronic neuroinflammation and neurodegeneration. So it kind of depends on its environment, whether it's going to be a good guy or a bad guy. And so we want to promote the good portion of microglia. Thanks. And hopefully the BTKI will prevent the bad side from turning on. Here's kind of another picture. You have a resting microglia in the middle, and then you have pro-inflammation if it goes the one way, anti-inflammation if it goes the other, and the environment and the chemicals around will dictate what happens to it. So really important to understand the microglia and try to turn it to the correct direction. This was a talk that was given in Milan in the fall at the large ECTRIMS meeting. Next. And I had several other slides along that line just to kind of emphasize that point. So microglia, they're believed to contribute to progression in MS. So we have relapses. We know most people, 85%, have relapsing remitting MS. Some start out with progressive MS, and some change from relapsing remitting MS to progressive MS. And microglia seem to be important in promoting progression of MS. So here, initially, you may have some cognitive issues and other issues and have some physical issues, but over time, then the physical issues become even more manifest, and then you start seeing more cognitive issues as well. And you see less inflammation as time goes on and just more progression, this kind of neurodegeneration. So we're hopeful that the BTKIs will allow us to address that part of MS. Now, before I go into this slide, which will sit up here for a little while, there's some other things to discuss. And one is PIRA. So PIRA is progression independent of relapse activity. That means getting worse without having relapses, getting worse without having any clear new lesions. And kind of the underworkings in the brain, partially mediated by microglia, partially mediated by chronic B cells that form follicles in the brain. And so PIRA is a newer concept, also called smoldering MS. That's just kind of working underneath the surface. It's had a lot of press in the last few years as BTK inhibitors have come to trial. There's been a lot of information out. You may have been inundated if you get MS literature about PIRA. And I like to be on the forefront of treatments, and have been my whole career. And concepts, I will caution just a little bit on PIRA, and I think it's a real entity. But stress worsens MS, clearly. Even last night, talking to someone, the doctor said your MS is progressing. Not so sure if you're having lots of health issues and other things going on. That impacts your function. I kind of look at MS as you are working on maximal reserve. And if you stress it out with a bladder infection, exposure to the heat, social stress, you name it, your function's not as good. And so if your general health is poor, that's a stress on your brain. If you're dehydrated, that's a stress on your brain. Brain is 80% water. So if you have a neurological condition and damage and you're not hydrating your brain, that's not going to be good for your condition. So just an elemental important thing. But the broad concept is that there are a lot of stressors. I have so many patients whose spouse has cancer, and it's a long 2-3 year painfully anguishing situation. Their MS doesn't do all that well. They don't have a new paralysis or go blind in an eye, but just cognitive fatigue, those sorts of issues are worse. And by the current definition, they'd be called PIRA. Their MS is getting worse, so we need to change therapy. I'd put the brakes on that and say, no, I don't know that your therapy is not the right therapy for you. You have a lot going on and you don't have a lot of reserve, and your function is expected to be worse. So I think there's sort of a gap in understanding the impact of stress. People who are trying to get disability, that's very stressful. You can't work, you have no income unless you have short-term, long-term disability policies. And it's a 2-year struggle, often rejected, and then have to appeal disability. That's extremely stressful that whole time, and you feel like you're not contributing to the family when you were before, et cetera, et cetera. MS doesn't work so well in those situations. From a practical standpoint, you wouldn't say I'm getting better, I'm trying for disability, number one, but two, it just is a huge stress on a person, so they generally aren't getting better. Right? And so would you say they have PIRA and let's change your MS medicine? I wouldn't. I'd say let's get through this process and let's see where you're at. Also, teachers, construction workers who go on disability, finally get disability, they feel so much better typically. They feel better because it's not that teaching or construction is necessarily negatively stressful, but you have to get up, you have to get ready, you have to go to work, you have to prepare things, et cetera, and that's a stress on the system. And when they don't have that, a lot of patients will kind of flourish, they'll feel better. And it's like, well, you shouldn't be on disability. No, you're not able to do that function, but you're able to rest during the day, you don't have all those additional stresses, and the function's better. That's not PIRA, and you don't get better from PIRA. So I think I just put a little bit of a caution on that concept. I think it does exist. I think it clearly does, but I think it's overcalled right now, and we need to pay attention to the stressors and how we can deal with stressors. Having poor health is not good. Having sugar out of control, having other health issues, blood pressure up, that's a stress on the system. Your MS isn't going to work so well. So we need to pay attention to those things. Now, there were two other major segments in the presentation that I wanted to talk about. And one is a new treatment that's coming now just to phase 3 studies. Frexalimab is the antibody, and it's really exciting. So it works on what's called a co-stimulatory molecule. When the immune system gets turned on, it needs another turn-on signal that says, yeah, it's okay, it's not me, you can go ahead and attack. And that's a problem in MS. The attack signal is generated, and that signal that says, don't attack me, doesn't happen. And that's through the CD40 ligand, and there's a CD40, CD40L connection, or ligand connection that needs to happen. And we see that there's problems in this system. The system is necessary to tell the cell when it gets old, you need to go ahead and die. So it's senescence. And when you don't have that signal, you have a lot more aging cells in your system, which aren't functioning very well and chewing up a lot of energy because they still need energy to live. That's a stress on the system. Also, it is believed, and there's several pieces of evidence, that the CD40 ligand is something that maintains the life of the cell, therefore maintains Epstein-Barr life inside the cell, which we don't want to have happen. So Epstein-Barr virus is a virus that causes mono, and also believed in the majority of people to actually trigger their MS. And it persists in your cells. And if you don't, your cells, and it kind of trains your cells, it has an anti-apoptotic signal. Apoptosis is programmed cell death. We don't want all our cells living forever and clogging up when they're time to go and have new cells and they need to go. And so the apoptosis is programmed cell death. Well, Epstein-Barr virus can stimulate anti-apoptosis to allow themselves to live within the cell and keep the cell living, which may lead to progression of MS. So this treatment, frexalimab, is one that binds B cells, but also microglia, and this through the CD40 system, so may impact the B cells from having acute attacks of MS, also work on the CD40 prolongation and the cells that don't die. So it's important. It's an important pathway and may have some extra benefits to it. So I'm really excited. We're one of the centers in the country to be enrolled in that study, or enrolling in that study. So we're happy to be so, and hopefully we have a really good result. And these were the phase 2 results of this treatment. There are 2 doses of frexalimab, low dose and a high dose. Both of them significantly impacted number of lesions over time. And next. Those are enhancing or active lesions. Then patients, the proportion of patients with new active lesions through week 24, very, very low, 4% patients with new active lesions through week 24. And this is an active bunch going into the study. Next. And then plasma neurofilament light chains are believed to be a biomarker of MS activity. And GFAP is a biomarker that also looks at activity, but also may look at progression. So we have some biomarkers that we're trying to work in individuals. Globally, they look to give us a signal, but there may be some variations with patient characteristics. So we're trying to get a good biomarker pool to be able to predict progression. Is someone progressing, or is it stress? Biomarker's not going up. It's not due to MS getting worse. We hope to be able to have something like that where then we don't make wrong decisions from wrong conclusions. Well, here, neurofilament light is expected to go up when a person has active disease. And you can see with frexalimab, neurofilaments going down consistently once one starts treatment. So it looks to be effective in MS, number one, but it also holds out a good bit of hope that maybe it's going to work on progression through this CD40 ligand. Next. One other segment of the talk I'd like to talk is biological age versus chronological age. So 62 back there may not be 62, it could be 50, it could be 80. And there are a bunch of things to look at biological age. And there are a couple different ways to look at these cells and their aging. There's something called a telomere, which is the end part of a chromosome. And as you age and you have some damage, those telomere lengths decrease. If you have 4 or 5 chromosomes with smaller telomeres, that's a senescent cell. It's not functioning too well. All you need is a few. And oxidative stress, health-related stress, cause an acceleration of that. So the best way to stop aging, and this is the science of aging, but also very relevant to MS, is that aging can be lessened by physical activity and better choices of diet. That can help to maintain telomere length longer. Now, there have been several studies about telomere length and aging. And your biological age is not necessarily your chronological age. So not all 60-year-olds are the same. And so we're trying to figure out what a person's biological age is, because there are several studies showing significantly worse MS scores in people who are older on the biological age index. And that index, there is one index. You can't just go have your blood drawn for telomere length, but you can have your lungs checked for forced expired respirations at 1 second. You can have your creatinine looked at, your albumin looked at. There's something called NHANES, NHANES is the acronym, and that is something practical that can give you a score. So biological age index that kind of helps to say what your biological age is. And there's strong correlations with an older biological age and worsening MS. So very important to try to limit that. There's senolytics, so senescence, aging. Senolytics are treatments that kill senescent cells, aging cells, can get rid of them. So you don't have to be bogged down with cells that aren't helping you yet are hanging around chewing up metabolism. And one of those is quercetin, and I think satinib is the other one. But there are two senolytics that are being studied at the present time. And then there are some others that try to reduce the stimulation to keep a cell senescent. And metformin is one that's really being studied in aging. Of course, many of you may know that for diabetes and modest weight loss in some people, but it's really in a number of aging studies looking at decreasing biological age. And there's several others, clemastine, which is an antihistamine. Other things that are looking for kind of remyelination are indomethacin and the generic of Seroquel, which I don't pronounce very well, so I have to use the brand name, sorry. So there are several things looking at trying to help with aging and also help to remyelinate that are being studied at the present time. So I think those are very exciting things. Now, not only preventing progression of MS and controlling MS is important in dealing with a chronic illness, but it's treating the symptoms and the comorbid conditions. So what's listed there, I'm not going to mention all of those, but what you see on the slide are a lot of hidden symptoms in MS. So again, as a caregiver, and I heard someone earlier say, I feel alone, no one understands me. Well, one has to deal with these things, and you can't see it. I can't see those symptoms in a person typically, but one has to contend with those along with the visible symptoms. So that's really challenging for patients. They can feel kind of isolated. No one understands them. Next. They're disappearing. They're hidden now, so cutesy. But so comorbid conditions. A comorbid condition is a condition that's paired with your base condition, in this case MS, genetically. So it's not a result of the fact that you have MS, but it's a package deal. It goes with your MS. Depression, anxiety, migraine, hypertension, those are conditions, sleep disorders. Those are conditions that occur genetically linked with MS and occur much more than what would be expected from having the condition. And I'm going to speak a little bit about depression and anxiety. And those of you who've heard me in the clinic, just hear it again. Parkinson's disease is a dopamine problem. And Alzheimer's disease is an acetylcholine problem. And diabetes is an insulin pathway problem. Hypertension is a renin or aldosterone chemical problem. Depression is a norepinephrine or serotonin problem. Anxiety is a GABA problem. So there are 6 conditions with 6 chemical pathways. Why do we treat people with depression and anxiety differently? Like they're not strong enough? You need to get over it. I put my happy face on when I'm sad. You're not praying enough. We don't do that to the Parkinson's or diabetic patient. And I think we gave it to mental health clinicians back in the 70s because we didn't understand the brain. Now we do, and now we understand the pathways. And it's a physical problem. It's not a mental problem. Now stress will make it worse, but stress didn't cause it. Stress makes diabetes worse. Your sugar goes up. Your blood pressure goes up if you get really stressed and you have hypertension. So it's not that stress causes those conditions and you're just frail. It's a genetic chemical pathway problem, and we wouldn't say don't treat Parkinson's, don't treat diabetes, don't treat Alzheimer's, don't treat hypertension. We wouldn't say that. So why would we say, oh, tough it out, don't take that junk, don't take Xanax, don't take antidepressants? No, that's bad. But we do. And you feel guilty, and then you're put into the point of feeling, oh, I can't tell anybody what I'm taking, or I feel ashamed that I have these conditions. These are comorbid conditions with MS. They're genetically linked. You didn't do anything to cause it. It's not a mental health frail problem. It's a real problem. And yes, you may be able to get by with your depression or anxiety, but I would challenge that you weren't made just to get by. You were made to excel. You were made to be your best, not just to manage. Same thing with fatigue. Oh, I don't want to take medicine for fatigue. I can get by the day. Well, yes, you got by. Was that what you were made to do? Were you designed to get by, or you were designed to be a bright light and shine your light? Not to advocate that everyone needs to be on medication for all of these things or at high doses, but they are important issues that don't need to be cast aside. People wouldn't say, well, don't treat your diabetes or hypertension. These are in the same ballpark. Most disabling symptom of multiple sclerosis is fatigue. It's not being in a wheelchair. It's not blindness. It's fatigue. Your quality of life, just imagine you who don't have MS, when you're most tired and you have to live like that 24/7, what your quality of life would be like. So it's an important symptom to manage, whether it's trying to manage sleep better or spasticity, which chews up your energy. If you're flexing, you're chewing up energy. So if you have a lot of spasticity, you're wastefully chewing up a lot of energy. We need to treat the spasticity. That might help your fatigue. Treating depression. So it's all important to manage. I'm not saying it's a pharmaceutical thing that necessarily has to happen, but we should strive for your best, and you should strive for your best. Next. Yeah, so a lot of people, and we've had some talks today that were more geared towards quality of life things and such, and that's really important. Had a patient from down south of here, went into the coffee shop and left her car running, came out and got carjacked. They didn't want any witnesses. So they ran her over 6 times, her pelvis area. And so the EMTs, she could hear him as she was going in and out of consciousness. If helicopter can't get here, she's not going to make it. Well, fortunately, the good Lord brought the helicopter. She impacted the people on the ground. She impacted the people on the life flight. She impacted the receiving emergency room. She impacted the people in the OR multiple times, impacted the people in the ICU. And the regular ward, she impacted people in the outpatient or the inpatient rehab unit, and then outpatient OT and PT people. And important for her, she brought some people to the Lord. She took 2 steps when she came in before she was walking without any assistance. So when she came to clinic, she took 2 steps. Don't know if she'll take any more or not, hopefully. But at that point, it just struck me to ask her, I said, so let's go to your deathbed and let's look back at your life. And spirituality is important for her. And I said, so you brought some people to the Lord that is very important to you. If you look back at what you did, would you go back and get run over again? Because if you hadn't, several people might not have been saved. All right? So our time here is fleeting. She believes she'll leap like a deer someday in heaven. And what was her impact when she was here? We kind of all look for the cush life. That's what our goal is, to be more comfortable. But if we have a belief, then that's where we're going to end up. So what can we do here? And we can be a light in all situations. Right? The daily circumstances don't change that. You can be a light in grief. You can be a light if you win the lottery. You can be very thankful and and so on. So you can be a light in any situation. So I hear a lot, and I have to deal a lot with people who feel they're a burden. Well, my husband can't go do that, or my wife can't go do that. They have to clean me, they have to feed me this. I can't do that. I can't do what I used to do. And that may be true, but whatever you used to do was in the past, and you can't move forward if you're looking back. So what can you do with what you have? What can you do to make this a better place? That's what's most important at any given moment. Our life begins at this moment forward. And letting someone help you blesses them. So I also have a lot of nurses, because more female predominant, nurses, teachers who are used to helping people, and they don't like to receive help. They don't want to ask for help. They say, I don't want to, that's not me, I'm not supposed to. And I just ask them to think about the people they helped, and what if they didn't allow her or him to help them? They blessed her or him by letting them be helped. And the same holds. It's a double standard otherwise. So if you're a very big giver and then all of a sudden you need help, well, take help. Because you like to give help when you are giving help. Others around you like to give help. Allow them to help you. It means a lot to them. And you're blessing them. So I think that's about all I have to say. Rural care. So we touched on that earlier a little bit, but someone from North Mississippi, not a lot of support, et cetera, et cetera. So the MS Society, 1-800-FIGHT-MS, you call and say, we'd like to start a support group, and they will give you the tools and so on to start a support group if that's what you wish. There's a lot of there's the MS Foundation, the MSAA, the National MS Society, which are there to kind of help facilitate. I need a doctor. I need someone who knows MS who is this or that. You call them and they may be able to facilitate things. Become more tech savvy, although maybe a little bit more isolated, a little more difficult. Becoming more tech savvy. There's so many programs, so much information online. You can do, one is severely affected. We still have the ability to do televisits since COVID. So that's something that is available, but also seek. So this is a small little community. So the town's 16,000, the county's about 75 or 80,000, and there's an MS specialist here. So seek resources. You may not think, oh, I'm living here, there's not too much. You might be pleasantly surprised that there are some things, some resources. And generally people who don't have a lot of specialists at their back will be a little more compassionate. Maybe you get a little extra care from your primary care physician or other people. So it's not necessarily a curse to be in a rural area and have health issues. It's a little bit more of a challenge, but now with technology and so on, it's something that we can manage. And you have support group systems. You can start your own support group, et cetera. So I think that's, from my memory, about the best I can do right now. And I'll be happy to entertain any questions that you have.
Thank you, Dr. LaGanke. I want to know where all the colorful pictures of your blooms are.
What's that?
Your bloomings.
Yeah, so 14-foot sunflower that started from seed about 6 or 7 weeks. I'm just 3 years into this gardening thing, so still a novice, but lots of really, really neat stuff. I got it on my phone if anyone wants to look at them. So, but they were intermixed in the program, so sorry about that.
All right, we have a lot of questions online. I'm sure there are a lot of questions in the audience too. I'm going to start here. I'm going to take next one. Actually, I should start on the other side of the room. Nah, I'll wait for you all. I'll get there in a few minutes.
Dr. LaGanke, can you talk about NIDA? Tell people what NIDA is.
Sorry.
And NIDA? And
NIDA.
then can you tell, is it possible to be NIDA and be non-ambulatory?
Have NIDA and?
Wait. Be non-ambulatory with NIDA.
Yes, so so NIDA, no evidence of disease activity, is really something that I've been preaching since 2000. So I wasn't smart enough to come up with the term, but I was doing talks like this about the home run of therapy. And that's no new lesions, no change on the neurological exam, no relapses. And I added in a well-tolerated fashion, so I called it the home run of therapy. Then someone got smart and called it NIDA in about 2012. And so now we strive, now that's what we kind of are striving for. We're striving to see no evidence of disease progression. It doesn't mean your symptoms can't vacillate from day to day, good days and bad days, but the actual condition is moving forward. We want to have no signs that that's happening whatsoever. And I actually had a slide that if you achieve NIDA at 2 years on a treatment, you have a really good probability of having NIDA at 7 years. So if we can control disease very well for 2 years, we have a really good shot of continuing to control it as long as we follow the rules and keep doing what we're doing. Excuse me. So if someone has a disability and they're not ambulatory, either from MS or other things, and they're at a point, yes, at that point on treatment, there can be NIDA from then forward. So yes, and we should strive for that. There's a trend to not treat people with secondary progressive. Oh, there's no proof that any medicine works. Well, proof that medicine works takes about 10 years in progressive MS. So there's no studies that long, but the absence of proof is not the absence of effect. So insurance loves that. Okay, you don't get any treatment. But the people who are more disabled and they're hanging on with their upper extremities and they're thinking, aren't those people, don't they need our strongest efforts to maintain that? They've already been ravaged enough. And so we should really strive for NIDA in someone who's not ambulatory as much as we possibly can, just like any other person. We should do it for everybody. Yeah.
I've recently been diagnosed with MS beginning of the year. What should my diet look like?
What should my what?
Diet, food, intake, nutrition.
Healthy. So there are many different diet plans espoused out there for MS. Back in the day before we had treatments, it was a swank diet, the no artificial diet. We did that in our house for about 8 months. Did not change one thing. Actually, it was much worse. I wasn't too sad that I got to eat some things after that, but I was sad that she wasn't doing well. But there's a lot of different diets espoused. The anti-inflammatory diet with no dairy, etc. I probably have more patients who say they feel better on that diet than otherwise, but that's far from a clinical study that proves that. There's the keto diet, and there was one individual who did really well on the keto diet, so then it became that's what you need to do to cure your MS, and that's a bit of a far reach. Not to say I'm glad that she's better, and that may have been the perfect thing for her, but that's not a large study to say that everybody will benefit from that and everybody should do that. That's a testimonial, and the placebo effect is positive 25% of the time. It's a real thing. And so when you have just a small number of people doing really well in something, you have to just kind of pay attention to that, hope that that's going to blossom, but evaluate that. And that stem wave therapy that you heard of earlier, I mean, it blew me away. One of my patients who had treated for a long time, paraplegic, couldn't move her legs for 15 years, would come and get some treatments to ease her spasticity in her legs for over a decade. And she received that therapy and she came into clinic and she moved, she goes, watch this. She had a twinkle in her eye that day and she goes, watch this. And she moved her left leg up. And I was just kind of speechless because I'd seen her so long. And so, even when I was at UAB in the 90s, she was a patient of mine and in their teens and just ravaged. And to see her move that leg was just amazing to me. And again, I have to say it's one patient, one treat. I can't espouse the treatment necessarily, but I'm very intrigued by it and would love to kind of evaluate that to see benefits for other people. But so the diet, back to, sorry, long-winded answer, Jamal. There are lots of different diets that are espoused out there. I think things in moderation is always a good is always a good principle. Too extreme is usually not tenable on the long haul, and then one rebounds because they can't stick to it forever and ever. So, using prudence, making sure you have a good balance, and also hydrating very well, and incorporating whatever exercise one can with their level of ability.
Okay, I have a two-parter. The first part is, earlier you mentioned biological age versus chronological age, and you also mentioned metformin.
Metformin?
I think that's probably a miracle drug, because I have a father, he doesn't have MS, but he has heart conditions, and I saw him last year and he was looking frail and everything, and then I saw him this year and he looked like he done just spurted up everything.
That's amazing.
He does everything, but he just sits down. He needs to get up and go to physical therapy and occupational therapy, and therefore I'm going to encourage him to do that.
Right.
I was diagnosed with MS 21 years ago. I didn't stop.
That's great.
I didn't stop at all, and I've done a lot of the things that you mentioned. I've done as far as nutrition and all of that. I've done variety all over. And part two of my question or statement is, you said mental health is physical and genetic, but then is it also biological?
Yeah, so that's genetic, so that's biological.
Okay.
So that's mediated through the genes, and then it's a chemical pathway that's off that usually occurs in those conditions. So that's why it's a physical problem. Now, it doesn't mean that there aren't mental health issues out there. There are, but core depression and anxiety are due to a chemical pathway problem that's generally genetically mediated, just like those other medical problems that I mentioned. So one doesn't need to feel like they're different because they have this chronic medical condition as opposed to someone else who has a chronic medical condition. But society, unfortunately, kind of makes people feel ashamed of having depression or treating their anxiety. And that's a further stress on the person. First, they don't feel well to begin with, and then everyone's coming down on them for trying to want to get better. So that's a problem.
But those that I come in contact with those different conditions, mental health, I am encouraging. I'm teaching them whatever I know to give them some encouragement in their lives to be positive.
Right.
And I'll continue to do so as long as you said the Lord's will.
That's awesome. Strive to be better. Yeah.
Okay, next question's here.
Okay, so you were talking about depression and sort of the importance of getting treated and doing the best to do what you can with what you've got. I have struggled off and on. I've tried a variety of antidepressants with a variety of mechanisms of action, and with one exception across the board, what I found is that rather than improving my depression symptoms, it just skyrocketed them. Is that something that you see, and is it possible that that's somehow tied into the MS?
Possibly. Pretty much any condition, not any condition is totally controlled in everyone. Some people don't seem to be very responsive to a lot of the things that we have, which is why we still need to progress in what we have to offer. There are other things like deep brain stimulation. There's ketamine treatments, kind of atypical things for depression in people who don't seem to respond well to the usual agents. And so I think it's continue to strive to find something. Don't feel like you're a lost cause or it's something about you. It's just I need to continue to persevere to try to find something. And there are things in the diet that can be helpful as well. So it's a total approach, not just take a pill, you're going to be better. That can be a part of it for sure, but there are other things as well. Keep striving. Yep.
You had talked about quality of life and how it affects MS. Could a person then potentially use MS as a reason to prove need of weight loss drugs to insurance?
The last part's a way for someone to get weight loss agents. Well, we're talking about insurance, aren't we? Yeah. So I think the name needs to be changed. That's just my personal. I mean, I don't think it's really health insurance. I don't think they're insuring health globally. I think it's not the main priority is to ensure that you have good health, especially when they contradict over half of what we ask for every day. But that would be very logical. Okay, being overweight is a stress on my body. I've tried X, Y, Z, haven't had sufficient results. Would you please allow me to take something that may help springboard me into better health, and my MS will be better and other things will be better? That seems very logical to me. And we can try that argument and don't know what would happen. Yep.
Thank you. Next, from online, and then Karen, there's a person up there, but let me take the online question first.
Can I get some water, please?
Yes.
Thank you.
Anybody want to bring the doctor some water? That would be great. Thank you. I'm look at all these people.
I'm not going to drink the pitcher though. So.
That's great. That's great. Thank you.
Thank you so much.
All right. The question be, how do we know the difference if we have aging or is it MS related?
Is MS what?
Aging, are we aging just poorly, or is the MS getting worse or more significant?
As we age worse, our MS gets worse. Now, that's the other thing about progression with MS and PIRA. Well, we lose normal neurons, and that's our reserve. Our MS may get a little worse as we get older, because we were relying on those neurons, and just normal aging, we lose some. So if we age poorly and have a higher biological age than we should, our MS will likely be worse and progress some. Those mitochondria that we have, the powerhouses of our cells that generate energy in our neurons, are there for our whole life. We don't regenerate any. So those poor little guys are working really hard. So we need to do all that we can to minimize stress on our mitochondria and our nervous system, because they kind of get weak and fade away, then we get a little bit worse. So all things, just think better diet, exercise as one can, keep your brain stimulated, do something for somebody else. All those are going to help a person age better.
Yes, I've got afibrillation, which I go August 5th to have an abrasion. But would the afibrillation cause MS problems to be worse?
Uncontrolled atrial fibrillation would expect you'd expect to have more symptoms. Now, it doesn't mean your condition is worse, your symptoms are worse. And that's a big thing, is that people, when they're stressed, they go, my MS is getting worse. Well, maybe your MS isn't getting worse. You're feeling worse, definitely. Your symptoms are worse. But it doesn't mean there are new lesions or progression that way. Now, chronic stress on the system likely is going to lead to progression of the disease as well. But atrial fibrillation, if it comes and goes, that's less of a stress on your system, though more of a risk for stroke. So you need to make sure you're on a blood thinner. But if one rate controls the atrial fibrillation, gets the rate controlled, that should minimize stress on your system.
It used to be high and low, now it's staying low, my blood pressure, in which they got me on blood thinner. And then after 6 weeks, after the abrasion, they're going to do a Watchman, because my red blood cells, iron, all that goes low. But within a year and a half, I got 46 lesions in a year and a half, in which that's when my heart started acting up.
Mm-hmm. Yep, chicken or the egg, and then COVID also. So COVID has led to some atrial fibrillation, and the vaccine has led to atrial fibrillation, both. So that's also something that's new in the mix of stress on the system.
Dr. LaGanke, y'all were talking about metformin a little while ago, and I was kind of getting the impression that you guys were in favor of the drug.
I'm intrigued by the drug. I don't have data to clearly say it does this or that. But it's being tested as a remyelinating agent in MS, and it's being tested as an anti-aging or reduce aging preparation in studies. So it's very intriguing, interesting, and hopefully will bear some fruit that way. So I'm really interested in that, but no, there's no hard and fast studies that prove this or that at this point.
I just know as a for people with diabetes, it had caused so many other issues, and of course those people that got put on Rybelsus, the weight loss and all that came with, to help them with hypertension and so many other issues for those with diabetes. I was just wondering why there was such a change in the discussion about metformin being a good thing when there's been so much research about the side effects and issues with metformin. I didn't realize it was being rebranded for other.
Well, I think all good things have another side in some people, and so nothing is for everybody. And at the end of the day, if it works, but it has too many side effects, then that's not going to be something that's good for a particular person. But it is being looked at for those particular situations.
Dr. LaGanke, you've said a word several times, and I've not picked it up yet. You're saying Purad or what do you
Pira.
say?
Pira. P-I-R-A. So that's an acronym for progression independent of relapse activity. So a person getting worse but not having relapses, and their condition is clearly getting worse. That's what PIRA is.
Okay, I have a question and something that hasn't been touched at all. What are your beliefs on things like THC to treat MS symptoms, things like that?
Okay. So the question is about THC and treatment in MS. I go to the largest MS meeting every year. It's in Europe, called ECTRIMS, and I've done so for quite a while. It's legal in a number of countries there and used for treatment of MS symptoms in other countries. So I have I've seen this a while at what it does, and I've seen what's presented is improvements in tremor, anxiety. Some people have weight loss and can't gain weight, so it helps with weight gain in those individuals. Can help with some spasticity, stiffness of the muscles. They clearly see those benefits in people with MS. The one caveat that they always say is if a person has significant cognitive issues at baseline, it's not good. They don't function well with the THC products if they have baseline significant cognitive issues. It's not good for their MS. It's approved in the state, but when it'll get here, who knows? It's tied up in courts. But I think in the people I've seen who have had synthetic THC or CBD of one kind or another, definitely some patients have benefited in their tremor and their spasticity and their anxiety related to MS from the treatment.
Okay, I'm only going to say this about myself. Please remember I said severe cognitive problems in my earlier questions, but you talked about your office doing a trial on some new medication, correct?
Yes.
All right. I know you also said you don't do the insurance, but do you know if insurance are going to pay for something like that, or?
So studies.
Also, can you switch? Because I'm on one right now, but I don't know if we're going to be able to keep on it due to some other reasons that I'm not going to bug everybody with. But anyway.
So general principles in research is that the pharmaceuticals that thankfully fund progress in MS, if we remember back in 1992, we had no medications for MS were approved. Now we have around 30. And so what a blessing that these trials have occurred and that funding's been provided to allow us to study those things. Generally, in a clinical trial, it's going to be a pharmaceutical trial typically, and they'll fund the study. So you don't have to worry about health insurance. while you're in the study on those products, because you're willing to take a little bit of a risk on an unknown and help the world to understand certain aspects of MS better. And so that's generally paid for in those situations. Now, one can't just say, I want to be in a trial. Most trials, you have to have disease activity showing, because if you're very stable, we're not going to necessarily see a positive effect of the treatment, and then it may not get approved because it was given to a bunch of people who are very stable already. So there has to be, usually going into trials, people have to have active lesions or relapses at some time point before the trial in order to enroll in the clinical trial. There are other trials that are not pharmaceutical that people, can join in as well to help advance the science. Those are also really, really important. And we typically have about 15 studies ongoing at our center at any one time.
Taking that a step further, for many that want to know that are over 60 years old, why are they banned from studies?
Great question. Probably because chronological age is looked at, not biological age, but it's usually 18 to 55. Most trials, I can cite the criteria off the top of my head, but 18 to 55 years old typically. Partly because the average, my mom lived up to it, average time of dying was 62 with MS. That was the average age of death before we had treatments. So things have changed, but the criteria haven't necessarily changed. And so people are living longer with their MS and more functional going into trials. I think some of the concern is from just general things, cancer, death from heart disease, et cetera, et cetera. If there's going to be $1 billion spent to bring a drug to market, which is the average cost to bring a medication to market, they don't want people dropping out for one reason or another. And so I think that was originally why it was at 55, because then people would pass, and that's no data for the study. It lost data, lost opportunity for a treatment for many people maybe. But I think people live a whole lot longer now, and I think that there should probably be a segment of that in a number of studies of a quote-unquote older population.
And taking things a step further, why are there some of the fantastic medications that have been around for 15 plus, 20 plus years that are now considered non-sellers, even though you knew that, how sorry to say, damn well they were working, like Atisabri? Why are the doctors no longer even prescribing this for patients when they knew that it was working for them?
Why are they not prescribing it?
Yes.
That's a problem. One of the slides on the presentation that I didn't have was that treating early with high efficacy agents makes a huge difference in your long-term outcome. So there's a study in Sweden that looked at if you were on what's considered a strong MS medication within 2 years, your outcomes were far superior to those who took 6 years to get to a high efficacy medication. We look back at almost all of our studies, many studies. We used to do placebo studies because we didn't have a lot to choose from. So I had placebo studies. And then when we had a stronger medicine versus a weaker medicine, at the end of the study, the people on placebo or the people on the weaker medicine are offered to go on the stronger medication if they want to. They never catch up. Every single study, their outcomes never catch up to the higher efficacy patients. So the push should be stronger medications from the get-go. I think some physicians are very hesitant about side effects, and none of us want anyone to have a significant side effect.
And yet there are still many of the doctors across the country that are just community neurologists that want to do escalation therapy.
Right, because I think part of it is if someone gets worse, darn MS, terrible condition, they got worse. If I give them something and they happen to have a side effect, I did it to them. So I'm going to cause no harm. I cause no harm if you go on a lesser agent and you get worse. I didn't do it. I don't think that's I planned that out, but I think that's maybe in the subconscious. And it couldn't be further from the truth. By not allowing a person to have access to strong treatment, you've almost written that they're going to have worse outcomes, and it should lie squarely on your shoulders. If everyone's going to escalation therapy, I would almost guarantee that you look at the populations over time, that patient population is not doing as well as one that's offered more high-powered medications from the get-go.
Like even today, you have your B-cell therapies, which are great, but we still hear from all across the country at our programs how their doctors just refuse to put them on these B-cell therapies, and they're still comfortable with a glatiramer acetate.
Yeah, I can't answer for them. That's not our practice. I think we should give the best opportunity to be neurologically as healthy as possible in a person's lifetime and not react to disability, but prevent disability. That's my philosophy.
Okay, we have a question.
There are some neurologists that recommend that a patient ages out of using a DMT. What are your thoughts?
So the question was, can you age out of your disease-modifying treatment? You get to 65, haven't had any problems in a while, do you still need to take that treatment? And that's a very good question. And in the days before we had treatment, we would see people who would get to an age and then just kind of what we call burned out. Their MS would burn out and they just kind of stay level. And if we could identify factors of individuals who could go off treatment and not have to take it and do what they're doing now, that would be wonderful. And there have been several studies, one at NYU. First study failed, 85-year-olds having relapses, and they hadn't had one in 30 years or so. Second one was pretty successful, only a small number of people relapsed, but there's a good push trying to identify those people who have certain features that might predict that they do fine coming off treatment, meaning no relapse in the last 10 years, no MRI change, cognitive this, that. So there's a push to try to find, because we don't want people to be on treatments that they don't need. So if you don't need it anymore, then we don't want you to take it. But it's kind of trendy now too. And that's a little dangerous because we really don't have good data to say that's a wise thing to do at this point.
Thank you. You all are so lucky to have this doctor here who wants all of you to remain as healthy as you can. Again, I'm bringing up a lot of questions because we do programs all around the United States, primarily in rural regions, and the people in these rural regions seeing these community neurologists, not MS experts, are going with what that doctor feels is comfortable for him or her to prescribe to those patients so that they don't have to live with guilt if something happens to the patient. Well, that's not really their call. And so we encourage people to get out to an MS center somewhere, even if it's a few-hour drive away.
Thank you. And thank you for coming out to rural America.
You're welcome.
Thank you for
this
hosting
area
this
is not
program.
rural anymore.
Thanks for hosting these programs.
This location is not rural when I first came.
So just to that point, before you ask your question, last year we had over 100-something people here. We're less than half of that today. And we wanted to maintain this here. And Stuart was talking about moving it to another city next year around this time. So you all could strongly encourage Stu to keep it here and spread the word and get more people here next year before he pulls the trigger and goes somewhere else before Stuart says anything. But if you feel that way, because I think it is good to come to rural areas, and the people from Birmingham and Huntsville have to get off their high horse, Sagri can drive an hour. Not those of you who are from there who came here, but those who use that as an excuse. They just, it's a one-day big symposium. Stuart hosts this another time of the year in South Florida. Hundreds of people come, big deal. And we were trying to mirror that up here, and we would love for that to happen, make this an annual event in this area. It doesn't have to be this town, but if it's supported, then great. But if you all feel strongly about it, please give Stuart some input.
Well, I would like to ask them all right now. I know there's people online, but I mean, you could answer online. I'll read about it when I get back to the laptop. But do you feel that being out in this weather is a hindrance for you?
Coming to the program.
And for the people online to know, it's in the mid-90s here right now, all right? But, the bottom line is that you're going to feel warm, but you get out into your car and you turn on the air, right? Right. You get out of the car, you come inside, and you're back in the air conditioning again, right? people ask me all the time, how do you live in South Florida in the heat? I say, God made air conditioning.
You know, the local professional teams when I was growing up used to have blackouts so that people would actually go to the stadium and watch them, because if they could sit at home, they didn't have to come. They didn't have to come to the program because they could get the program online, right? So maybe that's a little bit of it too. But I think there's something about being in person and fellowshipping, coming together that adds a little that you can't always come, and so online's a great opportunity. But you know, sometimes it's good to be together and talk. And plus, I'm going to be here to answer questions after, and you can't do that online, unfortunately.
We'll have to get a local large benefactor to help us put out the media, online media, like television, about this program happening. That would be great, right?
All right. Okay. Our challenge is accepted.
Who's got a few $100,000 to give me for that?
Who what?
Who's got a few $100,000?
We'll do what we can do.
I just wanted to hear your opinion on pain management overall.
Pain is present in MS, rather significant numbers, huge number of people with pain in MS. You know, when my mom was diagnosed at Yale, she was told, well, if there's anything good about MS, two things: you'll never have pain, and there are no cognitive problems with MS. That was in the 70s. So that was the thinking. We've come a long way since then. So pain is definitely present in quite a number of people. And, you know, with the opioid crisis, it really kind of modified some flexibility in treating people with chronic pain. We would prefer not to, you know, go that route if at all possible, but pain is pain, and when pain's present and you've tried a number of things, it's nice to have some other things available to help mitigate pain, which stresses the system. So pain's a real problem globally. It's a real problem in multiple sclerosis, and you know, it should be treated as aggressively as we're allowed to treat it.
All right, question on the far side? No? I have one here. Doc, somebody wants to know what CAR T therapy is about.
So CAR T therapy is a T-cell therapy that's trying to modify senescent cells too. And so I had a slide on that, unfortunately, that I can't reference to, but it's actually being used in Lou Gehrig's disease and so a bunch of autoimmune conditions, trying to have the T-cell modified T-cell to work on the immune system, and holds a lot of promise. It's rather new. It holds a lot of promise to treat a lot of immune conditions. There's not one that's available at the present time for MS, but they're being studied.
Thank you. Next person online writes, is there a way of testing specifically a patient's microglia?
No.
Okay, that was a quickie. All right, next one is stem cells. Can you give us what's happening in the world in stem cell research for multiple sclerosis?
Yeah, I wish I could be as encouraged about it as I was 20 years ago when we were talking about it, but still hasn't come to fruition to be something that's widely available, acceptable, paid for by insurance. The studies have not been appropriately done to prove that. People will go out of country to get stem cell treatment with mixed results, and some people do very well, some do not. Yeah, it's disappointing. I think it holds a lot of promise, but it's just been disappointing and not the fervent effort. You know, I think that would be a thing for the NIH, and because it's not a pharmaceutical, that's where research should go when our government funds are used, should be towards those type things. And they don't need to fund pharmaceutical things. They need to fund those kind of things that can be immensely helpful. We'll at least get an answer. We can stop talking about it 20 years later if it doesn't work, or we can have it available to treat people. It's been very frustrating. I think it holds a lot of potential. There are small studies with good results here and there, but the protocols are usually different, not the same, so you can't apply it broadly, unfortunately.
Okay, thank you. Next one. In your office, how do you work with a new patient who's been diagnosed with MS or who you diagnosed with MS, and how do you find what is the best treatment therapy for them with all these different medications on the market?
Yeah, that's a great question. The newly diagnosed patients, we have tons of medications available. We look at their lifestyle, how they're affected. But the general principle is going to be what we alluded to before, aggressive treatment from offering. Now, I don't put it into my body. Person diagnosed puts it into their body. So they have to be on board. So I offer and talk about different modalities, but ultimately it's their decision. Whatever their decision is, we will go with it and we'll do our best to have the best outcomes. But in general, we would be pleased if someone took a more aggressive approach, because we see just the benefits on the long haul from treating more strongly earlier, and not the benefits if you don't. So it's generally in that category. And we have categories, several medicines in the high efficacy, several in the moderate efficacy, and several in the low efficacy bucket. And so we'll talk about ones depending on what bucket a person wants to be in.
What's better than Lemtrada now?
So the question is Lemtrada status. So as I also said earlier, not any one medications for everybody. But we have had really good success by and large with Lemtrada treatment as far as stabilizing people, both from an MRI standpoint and relapse standpoint. That's an antibody treatment that's administered IV 5 days, 1 year, 3 days a year later, and then possibly never need to be treated again. And we have quite a number. We have the world's largest population treated. So we believe in that. Treatment, but we don't advocate it for everybody, and it doesn't necessarily hold everybody. So it's a very good agent. I think people are kind of, again, the Stewart's point, sometimes doctors treat what's convenient for them. I hate to say that, but monitoring labs every month for 5 years is not something a doctor wants to do necessarily. And I try to, when I speak to doctors in large arenas, they usually say, well, I didn't go to med school for convenience. I went for the best thing for the patient. Try to remind them of why they went into medicine, not to have the easiest way, but to do your best for your patient. And sometimes that requires a good bit more work. But the results, from the clinical studies were outstanding. But there's a lot of hesitation because you have to monitor labs, you have to worry about thyroid, and I think there's more concern about that than anything else.
Okay, next one, MRIs. How often should somebody get rescanned?
The general rule is MRI scan of the brain every year. Again, because 90% of lesions don't cause symptoms, we wouldn't know that there's more brain damage and things are moving forward if we just relied on the history or the exam. The spine, generally every 3 to 5 years, unless there are symptoms, new symptoms that are referable to any particular area, then of course we would get a scan as is appropriate. But as far as monitoring, just general rules, that's kind of the rules we follow and what the CMSC endorses.
Okay, next one. For your office, when medications do become generic or are no longer available in brand, do you recommend that the person use the generic of that product, or would you prefer that they switch to another high efficacy medication?
I generally am anti-generic in that setting. So it's a huge cost to medications. It's a big drain on the healthcare system, acknowledge that. But there are certain conditions that I think generics are not appropriate. Stroke. Go on a generic medicine that's 80% as powerful. Hadn't been tested, so roll the dice. Or 120% as toxic and have problems with bleeding. If you have epilepsy and you're stable and now you're going to go on a generic, you might have only 80% of the dose. And if you were getting another generic that was 120% of the dose and you're used to that, and then get one that's 80%, and you're driving a car and you kill somebody or yourself, well, that's really a terrible, terrible outcome. So life conditions that have one event that can alter your life. An MS relapse, 50% of people approximately never get fully over that. So 50% of the time in the high 40s, you have a relapse, you're going to be left with some baggage. You will not be the same person for the rest of your life. That's why we try not to have any of those. Stroke, epilepsy. So generics, which haven't been tested at those ranges of dose, I'm not for that. It's experimenting on patients for cost savings at the insurance level. That's why we do studies, to prove that something is beneficial, not just hope that it's beneficial at the cost of a patient so that insurance can save money. That's not what I'm about with generics in MS.
All right, before we go to the next question, there's somebody that's asking or saying something here that relates to this topic. And she wrote that her neurologist said that people with PPMS, primary progressive MS, don't need MRIs every year, according to her neurologist. What do you say?
Well, primary progressive MS, unfortunately, is a much more frustrating condition generally, because we haven't had any treatments until Ocrevus became available for primary progressive MS a few years ago. So to look and say you have more lesions and we can't do anything about it anyway would be a rationale for not necessarily getting an MRI every year. Sometimes there are questions of, you have some worsening, is it due to something else? And we would never be able to tell that if we didn't take a picture. So if a person has primary progressive is on a treatment, then I think it's advisable to follow the same rules. If one isn't on a treatment, then you just really have to look at, if I do this study, is there any advantage to having that information? If there's no benefit from doing the test applicable to the patient, then you should question whether you should do it at all. So that is a kind of a caveat situation.
Question in the middle?
Doctor, so I'm going to call these legacy medicines like beta-zeron and others. They're being successful in a lot of patients. Is there any concern that beta-zeron may be discontinued?
Good question. And so, we kind of pick on the lower efficacy agents and the clinicians who are using them pretty readily. But there are some patients who do extremely well. And, you don't need a Cadillac to go to the grocery store if the VW bug works well. So if the bug does everything you need it to do, you don't need to switch to something else. So if you're on a particular agent and doing well from, all the way around, then that's the appropriate medication, unless something might reverse it or something might confer an advantage over what you're doing. So yes, we pick on the legacy medications, but in some people, they're working perfectly fine and have for 20 years. It was the perfect fit for that person, and that's a good place to be. So I haven't heard that those are going to be faded out as far as availability goes. And I think maybe we could get it on compassionate care through the government. The government asks, if the pharmaceutical could give it on a compassionate care level if they stopped really pushing it. But I haven't heard anything to say that those medicines aren't gonna be available.
The concerns of clinical research not being not enough people are getting into clinical trials, and especially the African American community, as well as indigenous tribes, to get what's happening with them involved in the clinical research. How is your center able to get people to be involved, and are you able to reach out to a wider audience?
So I think in general, it's a little more difficult to go to enroll patients in clinical trials because the agents we have are very, very good for some. So to take a little bit of a chance on an unknown product, even though it's tested against another approved medicine, if we have kind of a pretty good chance of sustaining someone on a medication, it's a little bit more difficult to enroll a given individual into a trial. Now, as far as African Americans go, and this is before we had such agents, there did not seem to be as much enrollment in clinical trials. Some of that had to do with the fact that prognosis is worse as a general rule in African Americans, that their MS seems to be more aggressive. And especially if it's spinal cord, so there are certain things that say this is a more aggressive condition. So should we enroll in a clinical trial, which you may or may not get the product, or this may happen? It isn't because we're trying to exclude individuals. Like, that's not the safest thing to do. The safest thing is to use a very effective treatment that we have than to go in a clinical study. Now, I think it should be mentioned and talked about so that an individual has the opportunity. But I think in general, some of the larger MS centers might not enroll as many because they're more fearful that there will be more disability if we go in a clinical trial than a sure thing. So I think that's part of it.
Can someone with MS have narcolepsy along with insomnia? Can it be linked together?
Both of those have a higher incidence in MS than the general population. So they both are seemingly linked. Sleep disorders are considered a comorbid condition with MS, which is genetically in addition, not because of the MS necessarily, but that the genes for those travel with the genes of MS. So narcolepsy for sure has a really strong similar gene to someone with MS, and then insomnia has a host of reasons. So, working at that, that may or may not be, that may be something else, spasticity, having to get up at night all the time, anxiety, lots of other things that may cause the insomnia. But narcolepsy, surely genetically co-linked.
Okay. Last question. Access to care in rural America. For those that are not here today, how do you encourage them to get out and see a professional, so to speak, an expert? And where do they have the resources to find what they need as a family or as the individual with MS?
MS News and Views.
Of course.
Of course.
Thank you.
We do what we value. Not showing up today was what a person may have valued more than coming. So we do what we value at the end of the day, whether it's an action or an inaction. So they have to have a belief that going to an MS specialist or going somewhere is valuable, is helpful. It's worth the effort, the cost, and everything. And so hopefully we provide a service that is valuable for someone to come and spend their time and their money, to seek care. That's the bottom line, is, do I value it? And they also have to be educated to know that there are things, because some people, I think, believe there's not a whole lot to do when they're at a certain stage of their MS, but there are a lot of things to do. So they would value it more if they were educated more, maybe, and there are a lot of programs online for education. I do want to shout out my new nurse practitioner in the front. So she joined our team in the spring. It's Nina, so welcome to the team, and was a very good addition to our team. And then again, happy birthday to Miss Felicia. She gave up her birthday to come here to the symposium. So we were in clinic, and I made her a deal. I said, well, if you come, I'm baking you a cake. So she has a cake there, and thank you for spending your time, your special day here with us. Appreciate it.
All right, so we're wrapping this up. Again, thank you everybody for coming. We cannot do these programs without you. And so thank you. Thank you.